Hello everyone, let's start INICET 2022 anatomy paper. Actually, in 2022, there was lot of questions from the anatomy paper, May and November INI paper. Together, there was 37 questions. Okay, so let's discuss. Which structure is supplied by the nerve causing this elevation? Okay, they have marked this red color elevation, that is the facial colliculus. Okay, this is the elevation caused by facial nerve when it surrounds the sixth nuclei. That is the abducent nuclei. When the facial nerve turns like this elevation is formed. So now we have to see the facial nerve supplies which of this muscle, so that we will get the answer. This is a single liner question, but they are asking two questions in the single question. So here you have to see the facial nerve is supplying the risorius muscle. Okay, that is the muscle for smiling. Yes. Lateral rectus is supplied by sixth nerve. Superior oblique is by trochlear nerve, that is fourth nerve. Levator palpebral superioris is supplied by the third cranial nerve. So only risorius is supplied by the facial nerve. Here you can see the elevation of the internal genu of facial nerve around the abducent nucleus. Here there is abducent nucleus. This facial nerve takes a turn. This is forming the bulge there. The injury to the facial colliculus, first if it gets injured, the first nerve that is going to injure is seventh nerve, then sixth nerve. The facial muscles gets injured is more common than the lateral rectus, that is which is supplied by the sixth cranial nerve. Here cranial nuclei that is present in the fourth ventricle. Here this is the facial colliculus. Here the sixth nerve nuclei is present, whereas this is the hypoglossal trigon where hypoglossal nerve is present. This is the vagal trigon where 10th nerve is present, that is the vagus nerve, whereas this one is the vestibular triangle, that is 8th nerve nuclei is present. Okay. Hence, the answer is the facial expression muscle, that is risorius. Next, coming to the second one, which is not a branch of facial artery in the face. Okay, here first let's see the facial artery. This is the facial artery. This is the external carotid artery, gives a facial artery and also the maxillary artery. Maxillary artery gives a branch, that is the mental artery. But other than all the artery they have mentioned, lateral nasal, superior labial and inferior labial, everything is supplied by the facial artery. So here the mental artery is not a branch of facial artery. Let's see the diagram again. See, this is the external carotid branches. Here you can see superior thyroid, lingual, facial and maxillary, and this is the superior temporal, posterior auricular, occipital and ascending pharyngeal artery. This is the maxillary artery. You just have to know almost the names of the artery so that they can give this type of exception questions. So this is the maxillary artery. Here it gives an anterior tympanic branches. Then here it's going to the middle meningeal, and this is the accessory meningeal. Then it supplies to the anterior and posterior deep temporal and pterygoid branch. Also here you can see inferior alveolar branch, mylohyoid gives a branch to the mylohyoid muscle, and also it continues as a mental artery. It comes in the mental foramen. This is the pterygoid artery. It continues the spinopalatine artery, and this is the artery to the pterygoid canal, and this one is the pharyngeal artery. Here you can see inferior orbital artery, and this is the posterior superior alveolar branch and descending palatine artery and artery to the buccinator muscle. But facial artery, here you can see this is the ascending palatine artery. You saw there descending palatine artery is a maxillary branch, whereas ascending palatine artery comes in the facial artery, this one, and it gives to the tonsil, so tonsillar branch, and it gives to the submandibular gland, that is the glandular branch, and it goes and supply to the submental artery. This is submental is a branch of facial artery, whereas mental is a branch of mandibular artery, and it goes up and supplies inferior labial and superior labial and lateral nasal artery also. This is the masseter muscle, and above it supplies angular artery. It's an angular artery. Okay. Hence, mental artery is not a branch of facial artery. Third one, arrange the sequence of the structure involved in the direct pathway. This concept you have to at least see the revision video. If you don't get an idea, then see the main video. Okay, these are the nucleus of the basal ganglia. What is the importance of basal ganglia? Now, to start or stop a movement, the basal ganglia is very important. Basal ganglia acts as an inhibitory system to start or stop the action. So let's see. Basal ganglia is an inhibitory to both involuntary and voluntary movement even at rest. So if basal ganglia lesions will lead to resting tremors. So even at the rest, there will be the involuntary movements. Okay. First, this is the basal ganglia. You can see this one. Here you can see caudate nuclei, and here inside you can see the thalamus. Below the thalamus there is a subthalamic nuclei and substantia nigra, and this green color is the globus pallidus interna and externa. Putamen is commonly called as striatum. Okay. First, in direct pathway, the cortex is giving some information that it wants to do some action. So if you want to do some action, the inhibition should be taken away. Okay, so cortex will tell that striatum that I want to do a action, so it will go and tell to the globus pallidus, from putamen to globus pallidus interna. Then it will tell to the substantia nigra that the cortex want to perform some action, so the inhibition is gone here. The inhibition of the inhibition is gone. Okay, actually this concept is little bit tricky, so I recommend you to see the main video or a revision video. Okay, then so the inhibition to the thalamus is gone. So actually this everything are tightly bound. When the inhibition is gone, thalamus gets a freedom and it will perform a action. Then they will tell the cortex to form a action. You can do the action now. But in indirect pathway, what happens is that they are stopping the action. So they are making them to hold very tightly so that no action. So when cortex gives a signal for a stopping, so it will give a information to the striatum. So it will come and tell the globus pallidus externa. When they wanted to perform some action, they happily told to the interna, but now they want to stop the action, so they are telling to the externa, which comes and tells to the subthalamic nuclei. So subthalamic nuclei is the stimulant. Actually it will stimulate the globus pallidus interna. Now directly, if they tell interna to start the activity, then it's a direct pathway. If externa comes first, then subthalamic nuclei, then it is stimulating the globus pallidus interna. That means it is tells that not to stimulate thalamus. Hence, this globus pallidus interna and nigra together stops the thalamus. Means it will hold tightly thalamus, so it will not allow thalamus to do some activity. Hence, there is inhibition of movement. If normally the substantia nigra and pallidus will inhibit thalamus, so there is no action. But during direct pathway, this inhibition is lost and there is a movement. But here, by indirect pathway, there is inhibition, so there is no stimulus to the thalamus, hence there is inhibition of movement. I have repeated many times so that at least something goes into your head. Okay. If interna, substantia nigra and thalamus. Here in indirect pathway, the subthalamic nucleus also comes, and globus pallidus interna, then substantia nigra. Okay. So basal ganglia is holding the thalamus, motor cortex, then spinal cord. So if we see this, arrange the in direct pathway they have asked. So first one is a cortex. So fifth one, 5. So B and C are only the option which has 5 first. So A and D are ruled out. After cortex, it will tell to the striatum. So 5 1. After striatum, it will go to the, it is direct pathway, isn't it? So globus pallidus interna. So 2. Next from globus pallidus interna, then 3. Yes. Last is thalamus, and they tell the thalamus to start the movement. Yes. So option is C. Let's see some of the lesions of basal ganglia. If globus pallidus is injured, then patient will have athetosis, the snake-like movement. Putamen or a caudate lobe, C for C, there will be chorea. Subthalamic nucleus, hemibalismus. Tal for ball. Okay. Subthalamic nucleus for hemibalismus. Whereas substantia nigra is for dopaminergic neuron degeneration, then Parkinson's disease. Okay. Pill rolling movement will be there, isn't it? That's all because of this. Okay, third one done. Fourth one, arrange the structure of the cuboidal fossa in a sequence from medial to lateral. Okay, there is a famous mnemonic that is MBBS, isn't it? M for median nerve, yes, first one. So D is ruled out because 4 is given first. So M, okay. After that, B means brachial artery should come. So 4. Only C option is there for 4. Second one, brachial artery. Then again B for biceps brachii. So 3. Next, last one is superficial radial nerve. That is yes. That is radial nerve, superficial radial nerve. That is 2. Hence option is C. You can see the picture here. Cuboidal fossa. This is the medial side and this is lateral side. The medially is by the lateral boundary of the pronator teres, whereas lateral is by medial border of the brachioradialis. Radius comes means that is lateral. Okay, here they have given median nerve. This is the median nerve, and see, this is the radial nerve. This is the biceps brachii. This white thing is the tendon. Fifth one, injury of the lower brachial plexus leads to the clumcase paralysis. What is the characteristic clinical finding seen in this lesion? Actually, policeman receiving a tip is in the Erb's palsy. Whereas in clumcase paralysis, there is a claw hand. See, complete claw hand will be there. Injury to the lower trunk of the brachial plexus, mainly T1 and partially CA. The paralysis of the intrinsic muscles of the hand. When there is intrinsic muscle paralysis, it leads to the hyperextension at the metacarpophalangeal joint, that is MCP. When there is leads to the flexion at the proximal and distal interphalangeal joint. Actually, the intrinsic muscle helps in flexion at MCP. Hence, there is flexion is not possible. Hence, the hyperextension will overtake this. Extension at proximal and distal interphalangeal joint is also lost, hence there will be flexion. So this will lead to the claw hand. Okay. Next one, a 50-year-old male presented with the positive Trendelenburg test on right side. Identify the nerve injured. When Trendelenburg test is positive, it is a gluteus medius and minimus is paralyzed. So it is supplied by the superior gluteal nerve. Okay, but they have specifically asked right or left. So let's see the picture here. I have explained this in the previous paper also, but let me explain here also. This is the normal person. When he lifts off one leg, the other side will support the body, and this is the normal. See, he is lifting left leg, hence he will have a his body is supported by right leg. But now in the question they have told that rested on right side. When right side is away from the ground, left side will support the body. But when he lifts off his leg from left side, the right side is weak or paralyzed, hence it cannot support the body, hence it will sag on the normal side, that is here in the left side. See, when patient stands on the right foot, on his right foot, there is dropping of his left pelvis. This is positive Trendelenburg on right side. Okay, hence this is because of right side problem, right superior gluteal nerve is paralyzed. Seventh one, identify the cranial nerve from the marked part. This is the pons and this is medulla. This is pontomedullary junction. The medial side nerve is the abducent nerve. Okay, lateral to the abducent nerve, you can get a seventh nerve. You can see here. This is the sixth nerve, that is abducent nerve. This is the seventh nerve, both sensory and motor. Whereas this is the eighth nerve, vestibulocochlear nerve. Okay, hence the medial side is the abducent nerve in the pontomedullary junction. Eighth one, which of the following muscle is from pelvic diaphragm? Pelvic diaphragm, this is also a repeated question. Here you can pubococcygeus and iliococcygeus supports the pelvic diaphragm. So A and B, deep transverse perineum no, obturator internus no. Sometimes they give which of the following is not. That time you have to remember the ischiococcygis will not form a pelvic diaphragm. Okay. The other muscle is, you can remember, puborectalis also forms a levator ani muscle. This pelvic diaphragm is also known as levator ani. Levator ani muscle has a three muscle component, that is pubococcygeus, puborectalis and ischiococcygis. So option is A. Coming to the ninth one, which of the following is not a branch of posterior division of internal iliac artery? This is the repeated question. There they have asked anterior division actually. Here they have asked posterior division. Which of the following is not a branch, they have asked. There they have asked which of the following is not a branch of anterior division of the internal iliac artery. This time they have twisted and asked posterior division. In previous lecture I have told that it is easy to remember posterior division. So iliolumbar, lumbar is the posterior side, is lumbar vertebra is posterior, so yes, correct. Whereas lateral sacral is also posterior side, yes. And superior gluteal artery is also a posterior division. Only inferior gluteal artery is from anterior division. From the name only you can remember two things, okay? Iliolumbar and lateral sacral. But superior gluteal, one name you should remember, okay? Whereas inferior gluteal, see, inferior gluteal is inferior, right? It is coming very down, so it is coming from the anterior division only. But superior gluteal is very above, it is near the sacrum, hence it is from the posterior division. Okay.